The knee joint is a synovial joint of the hinge variety. It's an articulation between the femur and patella and the femur and the tibia. So it's a compound joint. However, the fibula plays no part in the formation of the joint and is not a weight-bearing bone, but serves only for muscle attachment. The joint, being a hinge joint, allows flexion and extension, which is the main movement like other hinge joints in the body. However, rotation of the femur on the tibia is only allowed during flexion of the knee. The stability of the knee joint, as any other joint in the body, depends on three main factors. These are the bones, ligaments, and muscles. The bony factor here is negligible and is only represented by the intercondylar eminence of the tibia, preventing side-to-side movement. Otherwise, the articular surface of the tibia is flat. The muscular factor is the most important factor. Many sport injuries are preventable through appropriate training. The most important muscle in stabilizing the knee is the quadriceps femoris muscle. This muscle, quadriceps femoris, when it undergoes atrophy during periods of disuse, like when the lower limb is in a cast, this will result in instability of the knee joint. Quadriceps tendon is attached to the patella. The patella acts as a sesamoid bone in this tendon, in the quadriceps femoris tendon, and through the ligamentum patellae, it carries the insertion into the tibia, the tuberosity of the tibia. Gluteus maximus and the tensor of the fascia lata, through their action on the iliotibial tract, are also important for the stability of the straight and slightly flexed knee. The other factor is the ligaments, and these are external and internal ligaments. This is a drawing of the knee joint from behind. The external ligaments are located outside the capsule of the knee joint, and they include the ligamentum patellae that has been just mentioned and the collateral ligaments. Two collateral ligaments, these are the tibial or medial collateral ligament, and this ligament is a broad ligament that is attached to the medial femoral epicondyle from one side and to the medial condyle of the tibia and the upper part of the medial surface of the tibia as well. The second collateral ligament is the fibular or lateral collateral ligament. This ligament is attached to the lateral epicondyle of the femur on one side, and on the other side it's attached to the head of the fibula. The fibular collateral ligament is cord-like, unlike the wide flattened medial collateral ligament, and the fibular collateral ligament is separated from the lateral meniscus. The lateral meniscus is located inside the capsule of the knee joint. In fact, both menisci are located inside the capsule of the knee joint. Let me draw the meniscus right now. So this is the lateral meniscus, and it's a little bit separated from the lateral collateral ligament. The lateral collateral ligament is not attached to the lateral meniscus. However, if we draw the medial meniscus, then we can see that the medial collateral ligament is attached to the medial meniscus. The other external ligament is the oblique popliteal ligament. The oblique popliteal ligament is an extension from the tendon of semimembranosus muscle. Semimembranosus muscle is attached to the posterior aspect of the medial condyle of the tibia. Oblique tendinous fibers extend upwards and laterally and constitute the oblique popliteal ligament that's important for the posterior stability of the knee joint. The other external ligament is called the arcuate popliteal ligament, and the arcuate popliteal ligament is a thickening of the capsule of the knee joint where the tendon of Popliteus muscle passes through the capsule. Let's draw the Popliteus muscle. Popliteus muscle arises from the back of the tibia above the soleal line. it has fleshy fibers. We can see them here. And the muscle will form a tendon that passes through the capsule of the knee joint. This tendon has few slips that are attached to the lateral meniscus, as you can see here, and the remaining part of the tendon continues within the capsule of the knee joint, separating between the lateral meniscus and the lateral collateral ligament, or the fibular collateral ligament, and the tendon of Popliteus is attached to the lateral condyle of the femur. Some fibers of the capsule of the knee joint, where the tendon passes into the capsule, are thickened and form the arcuate popliteal ligament as such. So far about the external ligaments. The internal ligaments include the cruciate ligaments, and these are strong bands that cross each other like the letter X. And they are named anterior and posterior according to their attachment to the tibia. Now let's draw the upper surface of the tibia. This is the medial tibial condyle, lateral condyle of the tibia, the upper surface, what constitutes the tibial plateaus, and this is the tuberosity of the tibia when looking at it from above. And these are again the intercondylar tubercles. So we have anterior intercondylar area and a posterior intercondylar area. The anterior cruciate ligament is attached to the anterior intercondylar area. So this is the area of attachment of the anterior cruciate ligament. That's why it's called anterior. If we draw it here on the posterior surface of the knee joint, then the fibers will extend upwards and laterally and backwards, of course, and will be attached to the lateral condyle of the femur. So this is the anterior cruciate ligament looking at it from behind. Now let's draw the distal end of the femur, a view of the distal end of the femur. This is the intercondylar notch, medial condyle of the femur. This is the place where there will be an articulation with the patellae, and this is the lateral condyle of the femur. Again, let's draw the anterior cruciate ligament arising from the anterior intercondylar area and attached to the lateral condyle of the femur. Now let's look at the cruciate ligaments from another view, that is from a lateral view. Here is the distal end of the femur articulating with the tibia. Here is the fibula, which does not participate in articulation, and so this is the site of the anterior cruciate ligament. The anterior cruciate ligament is the weaker ligament, and it prevents backward displacement of the femur on the tibia. Actually, it's the first ligament to be taught in extension of the knee joint, and where it can be torn when the knee is hit hard from the lateral side. And when the anterior cruciate ligament is torn, the tibia can slide anteriorly under the flexed femur. This is what we call anterior drawer sign. Now let's deal with the posterior cruciate ligament. The posterior cruciate ligament is attached to the posterior intercondylar area of the tibia. So here is how it looks from a posterior view. Of course, it's located inside the capsule of the knee joint, so I have to redraw the oblique popliteal ligament to overlap the posterior cruciate ligament, because the oblique popliteal ligament is a thickening of the capsule and the posterior cruciate ligament is located inside the capsule of the knee joint. So it extends from the posterior intercondylar area to the medial condyle of the tibia. Let's draw it on the diagram of the distal end of the femur, and here it is. This is the posterior cruciate ligament coming from behind. That's why it's called posterior, because it's attached to the posterior intercondylar area of the tibia and extends upwards and medially to the medial condyle of the femur. On this lateral diagram, we can represent the posterior cruciate ligament as such. The posterior cruciate ligament is the stronger ligament and it prevents forward movement of the femur on the tibia. Let me draw another diagram to emphasize the function of the posterior cruciate ligament. So in walking downstairs, the upper knee is flexed and it's at the same time it's weight bearing. And in this case, in the weight bearing upper knee while walking downstairs, the posterior cruciate ligament is the only stabilizing factor. So this is the posterior cruciate ligament location again. And as you can see, that it's the only stabilizing factor that prevents forward displacement of the femur in the weight-bearing flexed knee. That's why it should be very strong. Now, when the posterior cruciate ligament is ruptured, the patient leads with the damaged leg at each downward step. When the posterior cruciate ligament is torn, the tibia can slide posteriorly under the flexed femur, and this is what we call a posterior drawer sign. Now let's deal with the menisci. These are crescentic plates which are made of fibrocartilage. They are also called semilunar cartilages and they lie on the articular surface of the tibia. And as you can see here, that they are wedge-shaped in cross-section. They are thick at their peripheral margins and they are attached to the tibia by coronary ligaments around their periphery. Now let me draw the medial meniscus here. Each meniscus has horns that are attached to the intercondylar area of the tibia. So here are the attachments of the horns of the medial meniscus. Now let's draw the lateral meniscus. Again, it has horns that are attached to the intercondylar area of the tibia. Note that the medial meniscus is C-shaped while the lateral meniscus is almost circular. And this shape of the menisci is in conformity with the articular surface on the distal end of the femoral condyles. In addition to their attachment to the intercondylar area of the tibia by their horns, their attachment to the tibia around their periphery by coronary ligaments, the menisci are also attached to each other anteriorly by a transverse ligament. The lateral meniscus is also attached to the femur by two meniscofemoral ligaments. So this is one of the meniscofemoral ligaments here, and the other one is anterior to the posterior cruciate ligament. The menisci act as shock absorbers. In addition, they deepen the surface of the tibial plateaus, since their superior surface is concave while the inferior surface is flat, and also they adopt the tibial surfaces to the changing curvature of the femur during flexion and extension of the knee joint. You can notice here, for example, that the articular surface on the distal end of the femur is less curved than the posterior surface. And so the menisci, by opening and closing during flexion extension of the knee joint, they can adopt the tibial surfaces to this changing curvature of the femur. While doing so, they spread the synovial fluid within the joint. Now let me elaborate more on the differences in the articular surface of the distal end of the femur on the medial side and on the lateral side, and how is this reflected on the shape of the menisci. So this is the articular surface that articulates with the tibia on the distal end of the femur, and you can see that it is an elongated articular surface, elongated anteroposteriorly. And that's why the medial meniscus is C-shaped. On the lateral side, the articular surface is more or less circular. And as you can see here, that it is shorter anteroposteriorly than the articular surface. Don't be confused with this prominence on the anterior surface of the lateral condyle of the femur. This is the surface where the femur articulates with the patellae and plays no part in the articulation with the tibia. The articular surface of the tibia on the lateral condyle is circular, while the articular surface of the tibia on the medial condyle is oval and elongated anteroposteriorly. This is reflected on the menisci. The medial meniscus is C-shaped and the lateral meniscus is more or less circular. Now, if you appreciate this point, then you can easily understand what's going to happen during locking of the knee joint. Locking is an involuntary medial rotation of the femur on the tibia during full extension. And this locking, again I will repeat, is made possible by the fact that the anteroposterior dimension of the femoral articular surface is greater on the medial than on the lateral condyle. So during extension of the knee joint, the lateral condyle comes to the end of its run before the medial. So extension stops on the lateral side. And this is concomitant with tightening of the anterior cruciate ligament. Now, because there is more surface for articulation on the medial condyle, then extension continues on the medial side and produces medial rotation of the femur, which tightens the oblique popliteal ligament and the collateral ligaments. Now, this tightening of the ligaments will make the knee very stable, and this is what we call a locked knee. The knee being locked during extension, then flexion necessitates unlocking of the knee before flexion. Since locking of the knee is a medial rotation of the femur on the tibia, then unlocking is a lateral rotation of the femur on the tibia, and this is produced by Popliteus muscle. Popliteus muscle is described as a flexor of the knee joint, but this is probably an unimportant function of the muscle because there are so many powerful flexors like the gastrocnemius and the hamstring muscles. But this muscle being attached to the lateral condyle of the femur, then it can laterally rotate the femur on the tibia at the beginning of flexion, and this is what we call unlocking of the knee joint so that flexion can continue afterwards. Regarding injury of the knee, injury to the lateral meniscus is less common than the medial meniscus because the lateral meniscus is more mobile than the medial meniscus. It's not attached to the lateral collateral ligament, separated from it by the popliteus tendon. Popliteus muscle sends a few of its fibers into the lateral meniscus, and the lateral meniscus is also attached to the femur by the meniscofemoral ligaments. So the lateral meniscus may be pulled out of the harm's way during sudden movements of the knee joint. So during knee injury, think of the 3 C's, which indicate the structures that may be damaged: collateral ligaments, cruciate ligaments, and cartilage or menisci. Of the collateral ligaments, the medial collateral ligament is most likely to be torn, and this is commonly resulting from a lateral hit on the knee, abducting the femur on the tibia. Now, this rupture of the tibial collateral ligament is often associated with tearing of the anterior cruciate ligament, which is the weaker ligament, and at the same time tearing of the medial meniscus, which is firmly attached to the medial collateral ligament. The lateral meniscus, as I have just mentioned, is less likely to be injured if it is compared with the medial meniscus. There are a lot of bursae that may communicate or do not communicate with the knee joint. The largest of these bursae is the suprapatellar bursa, and this is actually, it's an extension, an upward extension of the knee joint. It passes between the femur and the tendon of the quadriceps femoris muscle and extends about 4 finger breadths superior to the base of the patellae. So a stab in the anterior part of the thigh proximal to the patellae may involve the knee joint because the suprapatellar bursa is in fact an extension, an upward extension of the synovial cavity of the knee joint. This is the infrapatellar pad of fat. It separates the synovial membrane from the patellar ligament. This is the synovial membrane here, and you can see that it's separated from the patellar ligament. The synovial membrane projects into the joint as alar folds. The alar folds, they form a vertical single infrapatellar fold which is attached posteriorly to the femoral intercondylar fossa. This infrapatellar fold almost subdivides the joint cavity into right and left. Let's go back to the bursae. We have a popliteus and gastrocnemius bursa and also a semimembranosus bursa. These are located posteriorly. I'm just going to draw it here as a representation. They also communicate with the cavity of the knee joint, as sometimes herniation of gastrocnemius and semimembranosus bursa into the popliteal fossa might result in what we call a Baker cyst or a popliteal cyst. The other bursae, which do not communicate with the knee joint cavity, are the subcutaneous prepatellar bursa, and this is located just in front of the patella, and this may be inflamed after prolonged working on the hands and knees. That's why it's called housemaid's knee when it's inflamed. The other one is the subcutaneous infrapatellar bursa, which lies between the skin and the tuberosity of the tibia. The subcutaneous infrapatellar bursa, when inflamed, the condition is called clergyman's knee because it's inflamed when kneeling. The other bursa that does not communicate with the knee joint is called the deep infrapatellar bursa, and this lies between the ligamentum patellae and the tibia, superior to the tibial tuberosity. When it's inflamed, it obliterates the dimples on either side of the ligamentum patellae when the knee is extended.